Diabetic ketoacidosis, or DKA, is a life-threatening complication of diabetes, often seen in type 1 diabetics. In this video, we'll explore what happens when routine is disrupted, using the real-world case of Danny, a new nurse practitioner who finds himself in a critical state. DKA case study, Danny's story. Meet Danny, diagnosed with type 1 diabetes at the age of 13. Danny managed his blood sugars meticulously throughout school, college, and graduate training. But starting his nurse practitioner residency changed everything. Late nights, missed meals, long rotations, and gradually his insulin schedule, once so precise, began to slip. After a night shift in trauma surgery, Danny grabs orange juice and donuts at 5 a.m., likely trying to prevent hypoglycemia or compensate for a missed meal. He grabs orange juice and donuts at 5 a.m. At 7 a.m., he drinks more juice, his thirst worsening. At 9 a.m., his heart is racing, he feels dizzy. He excuses himself from the OR and collapses unconscious in the call room. Danny is rushed to the emergency department. His vitals are alarming. Blood pressure, 90/40ths. Pulse, 130 beats per minute. Respirations, 32 per minute, deep and rapid. Glucose, 560 milligrams per deciliter. Potassium, 5.8 mEq per liter. Bicarbonate, 8 mEq per liter. pH, 7.22. Ketones, positive 3+. These numbers are classic for diabetic ketoacidosis, DKA. He's hyperglycemic, acidotic, dehydrated, and at risk for serious complications. Let's look at why this happens. In DKA, insulin is insufficient. Cells can't take in glucose, so the body burns fat, releasing ketones, acidic compounds that build up in the blood. Ketones and acidosis can cause confusion and fainting. Kidneys are overwhelmed, leading to massive fluid loss. Though well-intentioned, Danny's intake of sugary drinks worsened his hyperglycemia and osmolar imbalance, creating a vicious cycle. Danny's deep, rapid breathing, called Kussmaul respirations, helps blow off acid. This lowers CO2 levels in an attempt to compensate. His serum potassium appears elevated, but total body potassium is low. This is an illusion caused by acidosis-driven potassium shifts. Danny is admitted to the ICU. Treatment begins with aggressive fluid resuscitation, insulin therapy, and close electrolyte monitoring. Fluids and insulin are priorities, alongside frequent lab checks. Potassium is replaced carefully, watching for arrhythmias as insulin drives potassium back into cells. Continuous cardiac monitoring is essential during replacement. Sodium may appear low, but with hydration and correction of acidosis, levels typically normalize without direct replacement. Strict intake and output, neurochecks, and frequent labs guide therapy. ICU admission. Normal saline 30 milliliters per kilogram bolus, then maintenance. Continue 0.9% normal saline at 250 milliliters per hour. Switch to D5 0.45% NS with 20 milliequivalents potassium chloride when blood glucose is at or under 250. Start an insulin infusion at 0.1 units per kilogram per hour. Electrolytes checked every 4 to 6 hours. Strict input and output. Neurochecks. NPO until stable. Consult endocrinology and a diabetes educator. With timely interventions, Danny stabilizes. His acidosis resolves. Insulin is transitioned back to subcutaneous injections and education begins. Support from the diabetes educator and endocrinology ensures he has the tools to manage his health, even with a demanding schedule. Awareness, structure, and support help prevent recurrence. DKA is preventable, but it only takes one missed dose, one skipped meal, or one stressful night to spiral into crisis. Stay educated, stay vigilant, comment and subscribe for more clinical case studies.